Good morning, everyone. My name is Søndergaard. I'm a cardiologist based in Copenhagen in Denmark. It's great to see so many of you here in person, and also welcome to everyone who's joining us virtually. So we have seen that TAVI has been a great success, and now it's based on the recent low-risk trial is expanding towards patients at a younger age. And there's going to be quite a few challenges addressing these patients. One of them is access to the coronary arteries after inserting a transcatheter heart valves. So what we're going to discuss during this session here is about how to ensure coronary access, particularly how to obtain what we call commissural alignment. I'm joined here by my good friend Mohammed Abdel-Wahab from Leipzig in Germany. Mohammed is an interventional cardiologist. Mathias Götberg from Lund in Sweden. Mathias is also a cardiologist, and Andreas Rück from Stockholm in Sweden, also a cardiologist. So what we're going to discuss, if we can have the first slide up, the learning objective here is to talk about both the presence of coronary artery disease in patients undergoing TAVI and why it's important to access the coronary arteries afterwards. We're going to talk about why is it important to have commissural alignment of these transcatheter heart valve and how to actually achieve it. And that's going to be demonstrated by a live case demonstration. And also we want this session to be as interactive as possible, Mohammed.
Yeah, of course. So as usual, the session is interactive, so we would like to encourage you to ask your questions and use the chat function. Our chat master today is Michael Zembala from New York, and we would be happy to integrate all your questions into the discussion.
Yeah. So before we start, we can maybe have a short discussion here on the importance of coronary artery disease and how to handle this in patients. So Mohammed, what do we know about the prevalence of coronary artery disease in patients who's referred for transcatheter aortic valve implantation?
Yeah, so the prevalence is quite high. And we know from historic studies that particularly in the high-risk population, the prevalence may reach up to 70 or 80%, really depending, of course, on how you define the presence of coronary artery disease, which is variable among studies. The prevalence is a bit lower if you go to the low-risk population, but it may be even as high as 40 to 50%. So more or less every second patient we see has some sort of coronary artery disease.
Yeah. So most patients who got aortic valve disease or stenosis also have coronary artery disease. So that's really highlighting the importance of being able to access these coronary arteries. Mathias, most of the patient who is going for TAVI got, of course, a workup of the coronary artery disease arteries before. And as Mohammed said, quite a few got coronary artery disease, but most of them is asymptomatic. What do we know? Should these patients be revascularized before TAVI, or should we leave it?
That's a very good question. You know, I think for most of the patients, this is a question of that coronary artery disease and TAVI is a bystander disease. In other words, this is stable lesions, a part of chronic coronary disease. So we actually don't have much trial data. We have the 235 patient randomized trial called Activation that was conducted a few years ago, showing no difference at all between the patients on optical medical therapy versus those who underwent PCI for proximal lesions. We did find that there were more of the less severe bleeds in the PCI group owing to the adaptive therapy. And also there's an ongoing trial, a 450 patient Nordic trial called Notion 3 that is almost completed enrollment, looking at patients with either a very severe coronary stenosis or FFR positive stenosis, and randomized between PCI and optimal medical therapy. But like I said, I mean, I think that when we kind of lean back on historical samples, seeing that revascularization in coronary syndrome hasn't really yielded any great benefits. So if I would have to have a guess, I would say unless you have a very severe proximal stenosis, probably you don't have a benefit from revasc.
Okay, so maybe could you mention the activation trial, which we saw, was it last year presented, and then the Notion 3 trial. What's the main difference between the design of these two trials?
So both are randomized trials. However, it's a little bit of a difference in the primary endpoint because the primary composite endpoint in activation trial was death and rehospitalization, whereas the NOTION trial is more traditional death MI or urgent revasc. So I think in that sense, it makes more sense using a MACE endpoint, even though bleeding is of course tracked in the NOTION 3 trial.
And I also think in the activation, as you said, we didn't see any benefit of revascularizing these asymptomatic lesions before the TAVI procedure. But there was a trend to more bleeding in the group undergoing PCI, and that may be even more pronounced now because since the activation trial was conducted, we have seen that there's been a shift from dual antiplatelet therapy to single antiplatelet therapy after TAVI, and the patient who's undergoing PCI often have dual antiplatelet therapy. So there may even be an adverse effect of addressing these lesions.
Of course, and yeah, I think so, because single antiplatelet therapy is really the standard practice today, unless you have an indication for NOAC, for instance. So I think that we might show that the degree of bleeding in the conservative group may actually be even lower than we observed before. And in the activation trial, the degree of bleeding was quite high in the conservative arm, probably owing to the 1 to 3 months of DAF post-TAVI. And if we remove that, possibly we could see a harm in the PCI group. But we don't know. It's always kind of the benefit versus the risk. And I think that the difficulty is really that should we randomize even more high-risk lesions to kind of see if there's a benefit in PCI group. Usually these patients are not randomized in the trials.
So for the data we have so far, it seems that we should actually leave these lesions. We should not address them. And address us, of course, also give a higher probability that you need to go back afterwards to revascularize. And you got some insight from Stockholm about the need for accessing the coronary arteries after TAVI.
Yes, I mean, if we look into the literature, most of the literature comes, I think, from the time where we were more aggressive in treating coronary artery disease, also maybe asymptomatic stenosis were treated with PCI. And if we look at the follow-up of these patients, it seems like approximately 5% or around that will come back for a coronary angiogram in the first year. I presume now, with a more relaxed attitude to the coronary stenosis, we'll have more patients coming back. Maybe patients who have or still have some symptoms which could have been mistaken for aortic stenosis symptoms, and then maybe they come back to check the lesions. So I expect that this number will be considerably higher in the next years for patients coming back for an angiogram.
And also, one thing is a patient we see today, elderly patient with pre-existing coronary artery disease who are likely to need a coronary angiography or vascularization later on. But how do you see it as it potentially is going to progressing to patient at a younger age? There may also potentially be a need to access these coronary arteries in the future.
Yes, of course, our time horizon now for the patients is much longer than it was a couple of years ago. We're looking into 10, 15, 20 years of life expectancy, and then, of course, the accumulated risk of having a coronary event is higher in these patients.
So there are a couple of questions from the chat related mainly on how to define the presence of coronary artery disease in this population, which is sometimes quite challenging. So there's one question from Dinaldo Oliveira, how to define if CAD is responsible for symptoms, considering the alterations we have in the microcirculation, and of course the imbalance we have due to the presence of severe AS.
Anything you want to address, Matthias? What are you doing if the patient is coming forward? Because often the symptoms from the aortic stenosis can mask or be similar to what you have from coronary artery disease.
I think it's a great question. I tend to be a little bit more conservative, but if you have a patient that has severe coronary disease and obviously anginal symptoms as part of symptoms from the aortic stenosis, we typically do pressure measurement. We kind of lean to more towards doing IFR than FFR because there's a tendency for FFR to actually underestimate lesions. But if you have a borderline significant lesion, say IFR 0.89 or FFR 0.80, usually we leave that because the safety of deferral is quite high, whereas if we see highly significant lesions, very low IFR, FFR values, we have a tendency to revascularize based on that because Typically what we find is that we've done a previous paper showing that the aortic stenosis obviously contributes to the disease and the symptoms quite a lot. So an aortic stenosis equals to quite a severe stenosis in the coronaries. So if you're borderline ischemic before you perform TAVR, the likelihood of you actually coming back is quite low. So we just err on the side of being conservative.
So Matthias, just one question more. I mean, in patient without aortic stenosis, these physiological measurements has been the gold standard to determine whether the lesion is significant. There's been questions about you can use that in patient with severe aortic stenosis. Can you update on that, us on that?
You know, there aren't any large studies. We did a small study together with Imperial College a few years ago looking about pressure and flow in the coronaries before, and we found that there was an attenuation of the hyperemic response specifically in systole if you had an aortic stenosis. So you kind of blunt some of the hyperemic response when you're doing FFR. So if you're kind of borderline, obviously there's a tendency towards underestimation of lesion severity. If you're using resting indices, specifically looking at diastolic resting indices, you're a little bit more robust in your data set. But, you know, yet again, if you're borderline in terms of what you have, you should probably be conservative. So even though there might be a little bit of a mismatch between the two indices, and I'm leaning towards IFR, I think that still would kind of use the, borderline ischemic, try to be more conservative in these patients owing to the risk of bleeding.
There is also one question concerning the activation trial and how the results of this relatively small trial with, as you mentioned, an endpoint that is maybe not very comparable to other studies, how these results should be generalized to the general population we are treating.
You know, it's a good question. You know, if it were me, I'm leaning towards using the NOTION trial design looking at traditional MACE endpoints. I think that we're not really powered to see any difference between the two, because when you're doing a trial, you need to choose the adequate composite or constituents of the composite endpoint to actually know what you're tracking. And that might actually be what the case in the activation trial, that death is a kind of obviously a very dichotomous endpoint, but not a very granular endpoint. And rehospitalization, we know it happens for a lot of reasons. Most often it's complications from TAVR or heart failure, but not as much from kind of the ischemic risk. So I'm kind of waiting to see a little bit more what the NOTION 3 trial will show.
So Andreas, if you do not need to revascularize these asymptomatic lesions, is there any reason to do invasive coronary angiography on these patients who's under workup for TAVI, or could we just use the CT scan?
We have discussed that a lot in Stockholm, and we're leaning towards, since we need the CT anyways for the TAVR planning, to check the coronaries on the CT, and if they seem reasonably good, then we don't do an invasive angiogram unless the patient has ischemic symptoms.
Okay, so let's talk about how to optimize the access to the coronary arteries, because as we discussed, there's a lot of patients with pre-existing coronary artery disease, and it seems that we're less likely to revascularize them. As we're going to move to younger patients, there will be a highly likelihood they're going to develop significant coronary artery disease down the line. So Mohammed, maybe you can just tell us about the importance of commissural alignment.
So, I mean, we talked a little bit about the concept of commissural alignment. And, I mean, we learned also from this beautiful cartoon, now a very famous one from Lars and his group, what is meant by commissural alignment. And we know that surgeons, they usually implant the surgical valve with the neocommissures adapted to the native commissures, and this is what we may generally call commissural alignment. The opposite scenario, when you have the commissures in front of the coronary ostia, would be some sort of a commissural misalignment that you probably would need to avoid in order to obtain or preserve access to the coronaries. But we can define this even a little bit better using, for example, CT analyses afterwards, which has been demonstrated here in this very beautiful paper by Andreas Fuchs, published back in 2018. So you can define misalignment according to the degree of rotation of the neocommissures compared to the native ones. And you can divide this like in steps of 15 degrees and call it like mild, moderate, and severe misalignment if you wish so. But the real question is if we can accept a certain degree of misalignment and call this maybe clinically insignificant misalignment. And more or less, you can imagine a cutoff of around 30 degrees. So if the commissures are probably rotated up to 30 degrees from the native commissures, you may still consider this an acceptable form of alignment, but definitely beyond that, these commissures could be called misaligned. So is this important at all? And there are some potential drawbacks, of course, of malalignment. We are focusing here today on the impairment of coronary access, but there are some other theoretical benefits of having the commissures aligned, which we may discuss in the next minutes as well. For example, the difficulty of doing a redo procedure, or maybe we have some hemodynamic disadvantages as well. So to focus on the coronary access, this is a case that we've seen a few years ago, an old lady presenting 2 years after implantation of a portico device, so a self-expanding but intra-annular device. And she presented actually with an acute coronary syndrome, and you can see here the etiology of that is a severe stenosis at the ostium of the right coronary. But despite several attempts by several very experienced operators, we were not able to selectively engage or even approach this coronary artery in order to intervene on it. And at the end of the day, this intervention could not be performed. This is not very uncommon, and we've seen this paper published this year from a multi-center registry in the STEMI population, and you can see here some concerning points. For example, you have a significantly longer door-to-balloon time if you are treating a STEMI patient after TAVI compared to a STEMI patient without a transcatheter valve. You have a significantly higher failure rate of PCI, which is in these patients more or less unacceptable, and this is also reflected in a high in-hospital mortality, even exceeding 20%. If we get back to this case and we tried afterwards to analyze why did we fail, you can see here what I've shown you in the first slide, that in this particular case, this patient had a severe misalignment. So the commissures were exactly in front of the right coronary ostium. Coupled, of course, with a very small anatomy, so a very small or non-existing sinus of Valsalva, a very small STJ, there was not even room for manipulating the catheters in order to reach the ostium from each side of the commissure. And why is this problematic? I mean, you are all familiar with the transcatheter devices. This is for example, the ACURATE Neo2 device. And in all of these transcatheter devices, the commissures are much longer than the skirt. So of course, it's obvious that we will not be able to directly engage the coronary ostia through the sealing skirt, but it's also extremely difficult or actually impossible to achieve the coronary ostia directly through the commissures because they are covered. And the only way would be to try and access the coronaries from the side. The commissures, for your information, are mostly double as high as the sealing skirt. And there are some nice mechanistic studies done using post-procedural or post-TAVI CT that have also shown that the presence of a commissure in front of the coronary ostium identifies a subset of patients with unfavorable coronary access, which also reflects on the ability, the clinical ability to directly access the coronary arteries with various devices. So to summarize, and you can see on the slide, some potential points or aspects how to improve coronary access with current and next generation THVs, which is of particular importance when we are expanding this treatment to a lower risk population. And you can see here that one of the major points we need to address is to try and obtain commissural alignment with these different devices.
That's great, Mohammed. So maybe I can just continue here and show how to obtain commissural alignment in self-expanding technology. And there's different techniques, but I can show one here, how to do it. And so I'm just going to touch here on this ReAccess study, which was done by Marco Barbanti and the group from Catania, 300 patients undergoing TAVI. The physicians was asked to cannulate the right and the left coronary arteries before valve implantation and immediately afterwards. And you can see that in 23 patients, 7.7% of the patient, it was impossible to access both coronary arteries. And if you look at which valve was most problematic, it was the evolute valve with a supinal leaflet position, where it was almost 20% of the patient where it was not possible. Now, of course, that's going to be completely unacceptable to close the access to the coronary arteries later on for if the patient is going to be admitted with acute coronary syndrome. So what we need to do is the same as the surgeons are doing. We need to orientate these valves the same way as a native aortic valve is orientated to get commissural alignment. And it's been suggested by Gilbert Tang that for the evolute platform, instead of, as the company initially suggested, to have the floss port 12 o'clock, to turn it so you have the floss port 3 o'clock pointed to the left side of the patient. That's going to give you near commissural alignment in most patients. But of course, it's going to depend on how tortuous the access vessels is, how is the aortic arch, and how is the orientation of the aortic valve in the thorax. And you can see here that this is Gilbert's own data. With the floss port at 12 o'clock, you have 40% of the patient with severe commissural misalignment. And going to 3 o'clock, it's still 20%, the same number as we saw in the ReAccess trial. So it's better than not to do it, but it's still not sufficient. So what we need to talk about is what we call patient-specific commissural alignment. And you know there's been a trend to change the C-arm projection during TAVI from a classical LAO cranial projection towards an RAO caudal projection. And this is all about minimizing the risk of conduction abnormality and permanent pacemaker. We go to this cusp overlap view, where the right and the left cusp are overlapping during valve implantation. But that projection is actually also a very nice projection to obtain commissural alignment. Because in this projection, you're going to have, you see the eye here is the C-arm, right and left cusp are overlapping. On the far right of your fluoroscreen, you're going to have the commissure between the right and the left cusp. So the only thing you need to do is to make sure that one of the leaflet posts of the transcatheter heart valve is orientated to the right of your fluoroscreen during valve implantation. So here you can see with the ACURATE Neo2 valve, it's now across the aortic valve. You go to a cusp overlap view, right and left cusp is overlapped. You have the commissure between those two cusps pointing to the right of the screen. And on the ACURATE Neo2 valve, there is what we call a free stent strut, which is located just at the position of one of the leaflet posts. So the only thing you need to do is to torque on the delivery system until you see one of these three free stent struts are pointing to the right of the fluoroscreen. That's going to give you commissural alignment. And you see here, this is a live cannulation of the left main artery after valve implantation. And as long as you've got commissural alignment, it's very easy to engage the coronary arteries despite you have a supraannular leaflet position. And you can do that for most valves, but there's two factors which actually determine whether you have a successful commissural alignment. First of all, it needs to be easy to see the leaflet posts on the transcatheter heart valve. That's quite easy to do on the evolute platform and the ACURATE platform. It's more difficult on the current generation portico or navitor valve. The second thing you need to make sure of is that it's easy to actually to torque it. And you can see here for the ACURATE valve and for the portico and navitor valve, it's easy to torque the delivery system. For the evolute platform, it's a more bulky system, so that's why it's less easy. So again, two main factors to do it. It should be easy to identify the leaflet post, and it should be easy to torque the system. And in that way, I think the small study we did here, showing that the ACURATE valve is actually the best valve to obtain commissural alignment. So here, just to conclude here, commissural alignment is important. You can start to introduce the delivery system with the floss port in a certain direction. 3 o'clock for the Evolut platform, 6 o'clock for the ACURATE one. Then you go to this cusp overlap view, left-right cusp is overlapping, and you just make sure that one of the leaflet posts are positioned on the right-hand side of the fluoro screen. So this was a short overview, and I don't know if you have any comments you have, Mohammed?
Yeah, there are a couple of questions actually from the floor and from the chat asking about the difference between devices regarding the importance of achieving commissural alignment. So is it equally important with all types of devices? Are there devices where maybe it doesn't matter? Like if it's an intra-annular device, like Portico is a question. Is it really important to have commissural alignment, or is it more important with supra-annular devices?
Andreas, you want to address that?
Yes, just looking back at the Barbanti study, which I think was a beautiful study where all patients were cannulated before and after valve implantation. There was no strategy for commissural alignment, and still with the ACURATE, there was almost perfect possibility to engage both coronaries still, actually, despite the misalignment in presumably quite many patients there.
Yeah, but also when you can say that, I'm sure that the ACURATE valve, we have seen that's easier, maybe because of this upper crown is pushing, it's a bit away from the coronary arteries. But again, remember, if this patient eventually will come back with a failed valve, with a supra leaflet position, when you implant a second valve, you're going to push the leaflets from the first valve aside and jail in between the two stent frames. So you have actually, how should I say, a tunnel of tissue extending from the left ventricular outflow tract up to the ST junction, which of course we're going to make it impossible to access. You could potentially treat that by a kind of basilica technique. But again, basilica is only going to work if you got commissural alignment of your first valve.
I completely agree with that. So for long term, I completely agree. We should try to have the commissural alignment in as many patients as possible, for sure.
Yeah. And I mean, the case I've shown, it shows that it's also it's not only one factor. So if you have misalignment, you may be able to access the coronaries if the surrounding anatomy allows, but it gets more complicated if the surrounding anatomy is also hostile as well. So in very small ascending aorta, small sinuses, if you implant the device high, then you are making your life easier if you have alignment, at least removing one inhibiting factor for coronary access. Yeah.
So I think we have an excellent live demonstration from Lund and your team, Matthias. So maybe we can see that case, how to obtain commissural alignment.
So welcome everyone to today's Live in a Box case. My name is Matthias Götberg. I'm an interventional cardiologist at Skåne University Hospital. I'm here today with my partner, cardiothoracic surgeon Henrik Bjursten. Today we're going to discuss and implant an ACURATE neo2, specifically with the aim to achieve commissural alignment. We have a couple of slides showing why commissural alignment is important. Can we bring up the slides? So what I would first like to discuss is why commissural alignment is important when performing TAVR. Commissural alignment is when you align the commissural post with the native anatomy. And of course, it's important to simplify coronary access after you've done TAVR, but it's also important, especially in the younger patients, where you want to simplify and enable doing a future TAVR and TAVR. There are also further possible reasons, such as improving the sinus washout, but also potentially improving hemodynamics in the TAVR valve. As you can see in this slide, with the ACURATE neo2 bioprosthesis, you can clearly see the commissural post, both in the crimped state as well as the expanded state. And this provides us with the opportunity to do a commissural alignment. So the first step of the three-step process is actually starting off with the correct alignment. And this is insertion of the delivery system with the safety button or the flush port facing downwards at 6 o'clock. The second step is assessing the stalks. And we do this when we have the valve inside the annular plane. So immediately below these small corn cobs, you can see we have the 3 stalks. Here are the same stalks highlighted. And this gives us 3 different configurations. We have 2 stalks on the left and 1 to the right. This is 2 plus 1. We have 1 stalk on the left and 2 on the right. That's 1 plus 2. Or they're evenly distributed. This means 1 plus 1 plus 1. So 3 different configurations that we can see whether the valve is aligned or misaligned. How do we correct this? This is the third step of the process. If you identify a 2 plus 1 configuration, you do a clockwise rotation of the handle about 180 to 270 degrees while watching the 2 corn cobs and the stalks change into 1 plus 1 plus 1 configuration. Once you reach this configuration, you know you're aligned and you can implant the valve. Conversely, if you're in a 1 plus 2 configuration, you do the same thing, but you do a counterclockwise rotation of 180 to 270 degrees, and then kind of slowly watch the stalks traverse into 1 to 1 to 1 configuration, and then you implant the valve. If you're in the 1 plus 1 plus 1 configuration, most of the time you're in a good manner, because if you implant the valve, insert the valve in a configuration with the safety button facing downwards, in most of the cases you actually end up perfectly aligned. The thing is, though, is that when you are in the 1 plus 1 plus 1 configuration to start off with, you don't know if you're perfectly aligned or perfectly misaligned. So in this particular case, we have to swivel the C-arm into REO configuration, and we can look at the free cell and the configuration. So if the stalks end up in a 2 plus 1 configuration and this little free cell sticking out to the right, you know you're perfectly aligned, and you just go back to the 3-cusp view and implant the valve. Whereas if you end up in a 1 plus 2 view in REO, you know you're actually perfectly misaligned, and you have to apply some torque to watch the stalks travel to 1 plus 1 plus 1 in the 3-cusp view. And once they've kind of traversed that, you can implant the valve safely. Thank you very much. And now back to the case.
Thank you very much, Matthias. I will now go through the case briefly, and then we can go back to the case. This is an 80-year-old male. He had a previous NSTEMI, underwent CABG 17 years ago with the Lima to LAD, a vein graft to marginal branch, and also to the PDA. The ECG showed a prolonged PQT and broad or wide QRS complexes. The echo showed a moderately depressed left ventricular ejection fraction, a peak gradient of 71 millimeters, and a mean gradient of 40 millimeters, and an aortic valve area at 0.77 square meter. And the angiogram showed a patent Lima to the LAD and a stenosis in a marginal branch, and also an occluded vein graft to the right. He underwent a pre-procedural PCI towards that marginal branch, and as you can see, it was quite successful. The pre-procedural CT showed no annular calcification. There was, however, an eccentric leaflet calcification in the non-coronary cusp. The CT showed also good distance to the left main, the right coronary artery, and benign angle for implantation, and an adequate vascular access. So the procedure plan was a 14-French high sleeve introducer on the right side, transvenous pacemaker, given that he had a prolonged PQ time and also wide QRS complexes. 22 millimeter pre-dilatation just to crack open that calcification in the non-coronary cusp. And a medium accurate NEO2, and looking at sizes, this ends up very much in the middle of a medium accurate 2 valve. Thank you very much, and back to the procedure.
So here we have the ACURATE NEO2. It's a medium accurate valve. I'm using an eye sleeve, obviously, because it requires less expansion force. We're inserting it with the flush port or the safety button at 6 o'clock. I'm just showing the valve loader. So you need to keep it into 1, and when you insert it, it goes up quite smoothly. It's it's a very deliverable system. And we're going to see how it ends up in what kind of configuration we end up, and then we're going to do valve alignment accordingly. So you can see, if you look at my hands, you can see there's actually not much force going on. We bring the loader back, and then we push the valve into annular or just above annular configuration.
The flush port is pointing towards the table.
So this case is a little bit of a frozen cusp because it rides into the anatomy quite well. It's probably owing both to the deliverable system, but also to the fact that we've done a good pre-dilatation. If you look at the, here we can see the, we're not aligned in this case, so we need to do some torquing.
Would you say that you're deep enough here with the valve, or would you prefer to push it a little bit further before you rotate?
I think it's a good question. You know, we have a tendency to be inside the annular anatomy, but it sometimes depends on hemodynamics. But also, we've had a few cases where we found that we have more resistance to torquing when we're inside the annular anatomy. So it's really easy to torque. We stay inside the anatomy if it's a stable patient. Otherwise, we kind of back out a little bit and be just on top of the annular anatomy, as we are in this case. So here we can see we have a good 1-to-1-to-1 configuration after torquing. And it's really, we typically spend about 30 seconds doing this. So it's not really that complicated. And we try to do it as 2 steps. In other words, first we focus on the commissural alignment process, and then we venture further into the actual implantation, which is try to separate them. So once you've kind of finished your commissural alignment, you let go of that part. Pigtail and advanced. So we're just taking a little bit of time showing this. Any comments? You know, whether we should use cusp overlap view or 3-cusp view to do the commissural alignment. I'd say typically we tend to use more the 3-cusp view, but I think we can discuss that further a little bit once the case is done. Okay, so for NEO2, they have a radiopaque marker. You put that so it lies just on top of the cusp, and you have to have a forward motion. Not typically a lot of forward pressure, but you want to make sure you're on the outer curvature, and then you start turning the 1 knob into 1A configuration. You open up the first part of it, and you want to make sure that these upper crowns stay on top of the leaflets. So it's a very kind of slow, deliberate process, and hemodynamics is good throughout the process. You can see Henrik is turning the knob, and we see the deployment of the valve, just doing a final dive shot, make sure we're in a good position, and then we pull the pigtail back, and we deploy the valve finally.
In this case, check in REO projection that you were not completely misaligned. Maybe it's not in the edited version, is it?
No, we did not. Well, the reason is that if you are in 1-to-2 configuration or 2+1 configuration, you actually know. You have the directionality, so you know which way to turn, and you know you're going to end up aligned. The only time you actually really need to go into REO projection is when you start off in a 1+1+1 configuration, because you don't know if you're aligned or misaligned. But you know, I'm cognizant about that. It's probably visually a little bit easier to see the alignment in the cusp overlap view, whereas you know we typically do the implant in the 3-cusp view, so we prefer to stay in that. But it depends a little bit on you know how used you are, how experienced you are using cusp overlap view, but also whether you can do it. Sometimes you have extreme angles, so it's a little bit difficult to actually achieve a good cusp overlap view. So here we can see that the system has been retrieved and we have the wire in place. We typically exchange it for a pigtail just to make sure that we don't have any leak. So if we have the pigtail in place, typically you get, if you have the wire in place, typically you get a little bit more central leak. So what's your practice on this?
We do almost the same. We always check the REO. I know we might not always need it, but and actually we start with the REO, but I think it's not important for result. Here we have a perfect result anyways, and I must say for practical reasons we don't always exchange for a pigtail, but I think that's also a minor detail. If you, with the wire in place, already have a good result, then you don't need to exchange for pigtail.
Yeah, I mean, we use the cusp overlap view, as Lars mentioned as well. And we actually torque in the cusp overlap view, so we use the 3-cusp view to understand in which direction we are going to torque, but then we find it like easier to torque in the cusp overlap view. I think with your experience, probably doesn't make a big difference, but maybe for the beginners, it's a bit easier, I think, to identify what we are exactly looking at in the cusp overlap view.
It's a good question. I think that the main message really is that regardless of which nuance to the technique you're using, it's actually very easy to achieve commissural alignment.
Yeah.
I'm still in two minds whether to use just the three-cusp view or a cusp overlap view. Obviously, when we're doing evolute cases, we do a cusp overlap, but then again, we prefer to stay in the three-cusp view when you're doing the implant because it's really easy to kind of check the forces you apply on the system when you are doing the actual implant. So.
And it may be also one of the beautiful thing about this ACURATE platform that you can use. It's very easy to see it, and you have different techniques to actually obtain it. So it's probably the platform we have today where you have the highest success rate to have a commercial alignment.
Yeah, I agree. And as you can see, we had a perfect end result with no PVL, and we can see the corn cobs, the commissural post, and we see that we have a good commissural alignment. We actually moved the C-arm a little bit, but we can see that we have a good commissural alignment in this case as well. And I think that we really don't have many cases where we're not able to achieve commissural alignment now that we have awareness of it. I think the only cases you have a patient who's hemodynamically unstable where you want to rush the procedure a little bit, that's the only time we don't use commissural alignment.
But even in this case, if you go with a flush port at 6 o'clock, you have at least a very good chance to have a well-aligned valve, even if you don't assess every single step. Yeah.
So we have some questions from the chat. I think we can stop the video now and going to the questions.
The chat is quite active. So one question relating to the technique is about the torque of the catheter and whether this could lead to any damage to the catheter or any problems, like clinically apparent problems that are related to manipulating the device inside the native anatomy.
Well, there's been some extensive bench testing because obviously I think procedural safety is the most important thing here, and there hasn't been any issues. I think it's kind of owing to the fact that the catheter in itself is very flexible, and the hydrophilic coating means that it's quite easy to torque and transmit that torque to the valve. So the risk of having any complications of that is very low, and I haven't really heard anything at all among those who perform commercial alignment that had any complications from it.
As mentioned by Lars, the devices, of course, are different. So we're talking here about the ACURATE platform, and this is a flexible catheter. It's quite different with devices where the catheter is more stiff. So I think this is one of the advantages of a flexible catheter in general. There's also one question. The people are taking this maybe a step further. Can we do this as well if we have coronary anomalies or if we have a bicuspid valve, which is probably a bit more challenging to understand the anatomy and what we should be doing?
We actually started this because we're talking about commissural alignment, but you could also say we want to have coronary alignment, see where is actually the coronary taking off on your CT scan. And I would say that the left coronary artery is always taking out in a normal position, whereas the right, that's what you're going to see, is going to be more far away from the left, particularly if you have patients with bicuspid aortic valves. But even though you stick to the commissural alignment, you're only going to have mild to moderate misalignment in these abnormal take-off of the right coronary arteries. So you will be able, if you see in the CT scan, you have quite a lot abnormal take-off to adjust it, so you're going to have it. But again, remember what you're going to gain to have more close commissural alignment on the right, you're going to lose on the left because you shift everything around the.
Yeah, and this is actually also a problem for surgical replacement. So a surgeon would not be able to align perfectly if it's a bicuspid valve or if you have coronary anomalies. And this is sometimes what we see with surgical valves, and then we wonder why they are not perfectly aligned. So it's probably, as Lars said, you have to choose one of the two coronaries. Yeah.
Andreas, do you see any other benefits of commissural alignment? We have talked about, of course, it's important to be able to access the coronary arteries, but are there potentially other benefits of having commissural alignment?
Yes, I mean, now that we're implanting these valves into younger patients, we will foresee that many of them will have a failed valve in 10 years or so, and then we need to put another valve in. And like you alluded to, if it's a misaligned valve, then we might have a problem with either the left or the right coronary, or potentially both. But if it's a completely well-aligned valve, we could do a basilica and split the leaflet, and then there would be more flow to that coronary and potentially do a double basilica.
But talking about durability, do you think durability is affected about whether you have commissural alignment or commissural misalignment?
That's a very good question. I don't think we have a good answer. There is some speculation that maybe the PVL would be affected, since usually the PVL and the calcium nodules are bigger in the commissures, and since the skirt of this particular valve, the ACURATE, is actually not exactly the same around the 360 circle, the skirt is a little bit more floppy or loose just under these corn cobs or under the commissures of the valve, and potentially sealing better if it's well aligned. We don't know that yet. That has to be analyzed still.
So it seems that the design of these sealing cuff or skirt they have on the external is sitting just at the leaflet post. So if you position that leaflet post in the patient's native commissure, where you often have the PVL, there's at least a chance that you're going to have less paravalvular leak. And I also personally think that if you can orientate the valve as a native valve, I think you have better hemodynamics flow through it, and thereby potentially also better durability of these valves. So I think that's important. Again, we're talking about expanding TAVI to a patient who's going to live with this valve for many years and not only a few years. So I think we need to be more ambitious when we're expanding the therapy to these kind of patients.
There are a few questions on whether it's also possible to achieve commissural alignment with the balloon expandable device. So we talked about the variety of self-expanding devices, how to achieve. Can we achieve this with balloon expandable devices, is the question?
I think, again, the two options, the two things you need before to have commissural alignment is that you need to be able to identify the leaflet post, and to my best knowledge, it's not possible today with the Sapien valve to do that. And the second one is, of course, able to rotate it. But I'm sure you're going to see in the next generation valve coming out from all the companies, this is going to be flagged up, and they're going to make it easy to identify the leaflet post, and also to how to actually adjust for any misalignment. So I think just the next generation will take this into account when they're coming out. That would be my perspective.
And maybe one short comment, I think, from a surgeon. Surgically, we strive to have the coronaries clear at all times, including bicuspid anatomy. It is well controlled. So we're sure that you are.
But again, you showed a very nice case in the beginning, Mohammed, on the patient admitted with ischemia, where it was very difficult to access the coronary arteries. And Andreas, I know you are going to try to help us to understand what is your optimal chance to actually access the coronary arteries after the TAVI implantation, tips and tricks.
Yes, thank you for the introduction. So I have some data and a few tricks that could be useful in the situation where it might be challenging to access the coronary arteries. So first, there could be different situations. One situation is that the patient comes back to your center where you actually have access to the pre-procedural coronary angiogram and potentially to the CT. Then you can actually look onto that and use that as a map. But even if you don't have it, I think we as interventionists are a bit lazy with the angulation of the C-arm. Usually, if you just look into the literature, without even, this patient has a TAVI valve in, but if we would do the same CT without the TAVI valve, we would see that the optimal cannulation angle for the left coronary is not AP, but actually it's at least 25 degrees LAO and 10 cranial. And for the RCA, it's actually quite far out. It's usually 45 degrees or more is the optimal angle. So if we just start by using more optimal angles, that will help a little bit, potentially. Then, as alluded to, if the coronaries are not low, if they are above the ceiling cuff, seems like the coronary access in an aligned ACURATE valve should be quite easy. But we're coming back to the data to find out if that's really true. This is an example of a patient we had where we actually have a CT scan after the TAVI, And you'll see it's almost perfectly misaligned. You see the commissural posts which are very close to the red dot, which marks the left coronary artery. And despite the fact that the patient came back to us to a rather inexperienced operator and not using the optimal angles, actually you will see that the cannulation actually worked out without a problem. So it's possible to cannulate also arteries where the TAVI valve is misaligned, but still I wouldn't recommend to have misaligned valves, of course. Then this study, which has been alluded to already here, study from Italy, where they systematically did cannulation of left and right coronary artery before implantation and after implantation of different TAVI valves. They found the strongest predictor by far was the presence of an evolute valve. It was almost exclusively these patients where there was a difficulty or it was impossible to cannulate both arteries. Then other markers for possible problems with recannulation of the coronaries is implant depth, meaning that the higher the implant is, the higher the sealing skirt will be, and the more likely it will be that the sealing skirt is actually covering the height of the coronary artery. And a small other marker was alluded to previously to if you have really shallow space in the sinuses of Valsalva, it's more difficult to maneuver between the stent and the sinus of Valsalva, so there's less space for maneuvering if you have a shallow sinus. But that seems to have a minor importance in this study. So coming back to the evolute, where we probably have the biggest difficulty, it really matters how the commissures are sitting. Here they're marked in red, the middle commissure, but also where the coronary arteries are sitting with regards to the stent. So if you have open stent cells in front of both coronary arteries, then you're lucky and it should be quite easy. Then if you have your coronary arteries sitting more not in the open cell, but in the crossing of two cells, then you might still be able to engage if there is some space in the sinus of Valsalva, so you can engage not really coaxially, but come a little bit from the side or from above to engage the coronaries. So like I said, there are some simple tips and tricks you could use. You could potentially check the previous angiogram, then you have some idea of where to look. You could check the pre-TAVI CT if you're in such a center that you have access to that. Like I said, maybe start with using appropriate fluoro angles from the beginning, with catheter choice, potentially under size a little bit. So for left coronary artery, maybe rather 3.5 than 4 size. For right coronary artery, maybe try some other non-standard catheters if you don't succeed with the regular Judkins right. For example, multipurpose if you want to engage this more from above, or AR2. You might need to engage the coronaries not coaxially, but actually through an adjacent stent strut to reach the coronary. And if you need to do a PCI, then in that situation, quite often you have a semi-selective cannulation of the coronary artery. And then quite often you can still get the coronary wire in, and if you have the wire in, then you can follow with a guide extension, and that will then make the PCI much easier for you.
Thanks, Andreas. Great overview. Mohammed, is this the same catheter and tools you have in your institution?
Yeah, more or less. So I think it's important to stress that, particularly if you have a self-expanding device in place, you need to undersize probably, because the effective area where you're playing around with your catheters is getting smaller. And I think the use of passive catheters, as you mentioned, the Judkins, even for a PCI, I would prefer them. I wouldn't use a backup catheter. First of all, they're more difficult to manipulate in this smaller area, and then you don't really need this very large backup, because the stent frame gives you some backup afterwards. And I also have a very low threshold to use guiding extensions just to facilitate PCI afterwards. Maybe one thing we can discuss is the access route. If you know you are going to treat a patient with a TAVI device, do you choose a particular access? So you go right radial, left radial, femoral?
Well, I think we typically go radial. I think in the only cases where you wouldn't go radial, change to femoral, is if you have a lot of vessel tortuosity coming into the aortic route, because you typically need a little bit more ability to torque the catheters when you're engaging through the different cells, depending obviously which stent design you have. So, but we typically use radial for most of our cases. We know it's easy and we're comfortable using that.
So, and Andreas, the three of you are excellent TAVI operators, you're excellent PCI operators, but the patient may come into another hospital in the middle of the night with acute coronary syndrome. Do we need to teach these sites what we just talked about today, how to look up for the commissural alignment, what catheters, what tools they need to use? Are we doing a good enough job on that?
I think the steps of just understanding that you need to downsize your catheters, I think most operators probably understand that, but we can still improve the teaching with that, I'm sure. And of course, it's most important in the situation that you mentioned. If they come in the middle of the night, it's really an acute setting. You need to actually access the coronaries and do the PCI and open the vessel, and it's really important.
Okay, so I think this was a great discussion. I personally enjoyed it a lot. So we talked about that coronary artery disease is a very prevalent condition in patients undergoing transcatheter heart valve implantation. And also the data we got so far from the activation trial show that maybe we should not revascularize these asymptomatic lesions, which of course mean that there will be a higher risk of later revascularizations, need for revascularization after TAVI implantation. And also as TAVI is going to expand to patients with longer life expectancy, quite a few of these patients will develop coronary artery disease down the line. So there is a high need for having easy access to the coronary arteries afterwards. We have seen, if you understand how these valves are designed, the fluoro markers on each valve, you can actually quite easily obtain commissural alignment for most of these valves, which of course is going to facilitate easier access to the coronary arteries later on, but also may be important in reducing the paravalvular leak, improving durability, and also subsequently, if you're going to do a TAVI in TAVI procedure, to do a kind of basilica technique to secure coronary access after a TAVI procedure. We also talked about which catheter, how to actually to try to engage these coronary arteries after a TAVI procedure to optimize the chance to do that. So with that, I want to thank you, Mohammed, Matthias, and Andreas for a great discussion, and also to Michael as a chat master, and for you to attending the session here, both in person and virtual. Hope you're going to enjoy the rest of this meeting. Thank you.